Okay, folks. So good morning, everyone, and thanks very much for joining the Department of Surgery University rounds. And it gives me great pleasure today to lead off with the tile lecture introduction. And in a moment, I'll be introducing our guest speaker, Dr. Avery Nathans. But just before that, the land acknowledgement I wish to begin with. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Our treaty obligations and commitment include learning about the history of these lands and territory and the structured dispossession that Indigenous nations have been subject to by Canada, and learning about justice, equity, structures of power, and to imagine how to build social relations for a different world. We affirm our solidarity with the Indigenous peoples of this land struggling for their self-determination and sovereignty from settler colonialism. Well, just a word about the past, and here's this obviously is 2022 tile lecture in trauma. But we're delighted today to have Dr. Marvin Tile with us on the line on the screen. You'll be able to see him, of course, and then hear from him shortly. But in a word, founder of the Sunnybrook Trauma Unit, professor of surgery at the University of Toronto, former chief of surgery at Sunnybrook Health Sciences Centre. Something you may not know about, but was really a huge deal in its day, and to the present time is a founding president of the AO Foundation, which has had fabulous success over decades now. A member of the Order of Canada. On the left-hand side, you can see Marvin here with James Kellum as a former tile lecturer, and Avery and myself from 2015. Other tile lecturers, here's Jeff Manley, Thomas Scalia, and Colonel Elon Glassberg, Rob Riddell, you may recall, and then last year, a very powerful talk by Joseph Saccharin. But this year, our tile lecturer is going to be Dr. Avery Nathans. He had his MD from Queen's University, PhD from the IMS at U of T, residency in general surgery, did his fellowship in trauma at Harborview in Seattle in 2000, full professor in 2008, surgeon-in-chief at Sunnybrook since 2012, a member of the Canadian Academy of Health Sciences, won the Lister Prize in the Department of Surgery, medical director of the Trauma Quality Improvement Programs at the American College of Surgeons since 2016, numerous peer-reviewed grants, and well over 450 peer-reviewed publications. I don't think we could have found anybody better than Avery to give us the tile lecture this year. Normally, as you all know, we invite speakers from outside, but this year, I think it was fortuitous for us to be able to have Avery give this lecture. I'm delighted that he'll be giving it shortly. Now, Avery has served on our executive committee. You can see him front and center in the back row here with my colleagues in the executive of the Department of Surgery who have served very capably with me, and I'm very grateful to all of their services and help these past 11 years. So just before turning the program over to Avery and inviting him to give the tile lecture, I'd like Marvin to say a few words. Marvin, I'm going to stop sharing, and it'd be great if you say a few words on behalf of the lecture in your name and honor. And it's really great to see you, Marvin. Thank you very much for appearing today with us on the Zoom call.
Well, thank you, Jim. I feel blessed that I'm still able to be here, that's for sure. And also, as I mentioned before, my wife has just spent some time, so I'm looking at the other side of the trauma program right now as the husband of a patient who was in for 3 weeks. Trauma began in Toronto on July the 1st, formally 1976, with the opening of the Sunnybrook Trauma Unit. It took us 5 years of lobbying to get the Davis government to approve it, and it has changed remarkably during that period. There were only a couple in the States. Many in the States were treating gunshots. We were treating mostly industrial accidents and car accidents. And now there's been a significant change. I'm also very honored to have Avery Nathan give this lecture. He's been a tower of strength in the department at Sunnybrook during this rather interesting time to be a leader. And you as well, Jim, have been fantastic as the leader of our entire department. So I'm looking forward to this talk, and over to you, Avery.
Thanks so much, Marvin and Jim. It really is an honor and a privilege to be able to give the tile lecture, to recognize, Marvin, all your contributions to trauma care in Toronto, and really setting the path forward many years ago that got us where we are here today. What I'm going to be focusing on is a program that we put into place within the American College of Surgeons. And you'll see that this, while the focus of this talk is trauma, it's actually broadly applicable to all of surgery and actually all of medicine. Before I go forward, I'm going to just disclose that I am an employee of the American College of Surgeons. As Jim mentioned, I run the trauma quality programs, which include both the ACS Trauma Center Verification Program. So we set the standards for trauma care in the United States with about 500 trauma centers. And I also run the Trauma Quality Improvement Program, which is basically the trauma equivalent of NSQIP. And we have about 850 hospitals in that program from around the world. So I'll be presenting some information from those programs, hence the disclosure. What I'm going to try to do is highlight and give you some background on where this aspirational goal of 0 preventable deaths came from. And to give you a sense of a framework for understanding human error as it applies to trauma care and also more generally surgical care. I'll provide some examples that are outside of trauma. We created this preventable death mortality reporting system in trauma, and I'll share some results with you and some learnings that I think will have you think differently about error prevention in your own hospitals. And those error prevention strategies are something that I think are important to bring forward because the way we've been doing it for years isn't working. So there'll be 3 take-home messages. First, all of us who provide medical care, surgical care, are going to be holding the ball when the adverse event occurs. Okay, what I mean by that, you'll be the provider at the sharp end. It'll be you who feels responsible for what happened. When you look at these events, it's important to dig deep, really deep, and ask why this happened. There's good data that suggests that high reliability organizations, these are typically nuclear subs, nuclear power plants, the aviation industry, have this tendency to avoid oversimplification. Okay, so the solution that's in front of you is probably not the right solution. The reason why it happened is probably not what you're looking at. It probably is something that's a lot deeper than that. So if you want to provide highly reliable care, you have to dig deep. And lastly, you'll learn that you have to use effective strategies for preventing adverse events that take into account that we're human and that we work in very complex systems. Just trying to change there we go. So this goal of zero preventable deaths comes from the National Academy of Sciences, Engineering and Medicine report that was published in 2016. This NASEM report had a number of recommendations. The focus really was, combining both civilian and military trauma, but ultimately designing a trauma system that would lead to a much higher rate of survival in the United States. And in those recommendations and in that monograph, using a variety of papers from the literature, they identified that probably about 20% of all trauma deaths in the United States might have been preventable. The preventability has to do with what happens in trauma centers. It also has to do with what happens in trauma systems. So if you can't get patients to the right place at the right time, that's a potentially preventable death. So up to 30,000 preventable deaths in a single year in the United States. The other thing that was evident, and this comes from data from our Trauma Quality Improvement Program, is that where you receive care really impacts your outcome. So when we compare the highest performing versus the lowest performing trauma centers in TQIP, there's about a 2-fold difference in mortality. So it does matter where you get your care. Now, when I speak of quality, I think all of us probably have different interpretations of what quality means. And really, quality is multifaceted. Okay, so quality actually has 6 domains. There's the safe domain, which basically is avoiding harm. And that'll be the principal focus for the talk today. but also providing evidence-based care is a measure of effectiveness, and that's a measure of quality. So what are the processes of care that you're providing to your patients? There's patient-centered care. Are you providing care that's guided by your patient's preferences and values? There's timely care, reducing waits and harmful delays. I would say this domain is really a challenge in our system, particularly now with the backlogs. There's efficient care. Okay, so are you providing cost-effective care? And are you providing equitable care? So that's care that's similar across gender, race, socioeconomic status. And that became evident again during the pandemic, that perhaps the Canadian healthcare system wasn't as equitable as we thought it could be. So quality is multifaceted. The focus today is primarily around safety. And the other thing that is often confused when we think about quality of care, we mix up error reduction versus quality improvement. And errors really are events that occur at the patient level. It's the failure of a planned action to be completed as intended, or if you use the wrong plan to achieve an aim, usually at the patient level. When we focus on quality improvement and quality of care, it's actually a much more holistic concept. It's the degree to which health services for individuals and typically populations increase the likelihood of desired health outcomes. So when you look at your outcomes over a population, that's really quality of care. When you're looking at specific events, you're focusing typically on errors. There are some relationships between the two, and I'll give you an example of that coming up. And here is that example. So this is a patient, BT, who had a high T-spine injury, a spinal cord injury, and was paraplegic. So this patient spent a number of weeks in hospital, in part because his course was complicated by a pressure ulcer. So this is a big problem. A pressure ulcer in a cord injured patient adds weeks and weeks to the hospital stay, and also dramatically extends their rehabilitation period. It's a big problem for these patients. Okay, so we recognized that we had a problem with this at Sunnybrook. In fact, this is our rate of pressure ulcers in cord injured patients. So we actually got as high as probably about 20 to 25%. We had the last quarter, actually we had no pressure ulcers in cord injured patients. So we've done a lot of things to try to improve this, but we knew we had a problem with this. And we embarked on a QI project to try to fix this problem. But in the process of developing this QI project, we actually had an error that really led us to understand what was happening. So the error, we had a patient who came in, there was a patient BT, and you see that red board on the left. So every patient who comes into the trauma bay is on a red board. That red board is supposed to be designed to allow patients to be easily transferred from one stretcher to the other, from the trauma bay stretcher to the CT stretcher to the OR and so on. So the error in BT's case is that the red board was under the patient for 17 hours. Multiple providers talked to the patient, saw the patient, evaluated the patient, and no one questioned this red board under the patient. It's a hard board, and it dramatically increases the risk of pressure ulcers. Okay, so we had a red board problem in addition to a spinal cord pressure ulcer problem. So we did a number of things to deal with the red board problem. Okay, so slider boards basically were removed from the trauma bay. If we needed one, they were available in CT to transfer the patient onto the scanner table, but they came out of the trauma bay. We made sure they were available in the scanner. There were signs all over the place saying, just use this for the purposes of transferring patients. We had reminders on the CT exit doors to make sure that the red board was gone. We had a formal policy on slider boards. And we just emphasized the importance of the culture of safety that anybody can speak up. If there were 20 or 30 different providers who saw this patient on the red board and no one asked a question, then it's a culture problem. We added to this a variety of things that tried to address the problem more broadly. We have special spinal cord injury beds now. We have skin assessments done throughout the day. We have turning clocks that require the nurses to actually turn the patients in the ICU every 2 hours, and a variety of other protocols. So an error kind of led us in this direction. We designed a QI project around this problem, which actually has, again, dramatically reduced the incidence of pressure wounds in this patient population. So that's an example of where there's an error. There's also a QI opportunity. Now, there's a lot of analogies with healthcare to the aviation industry, and I'll give you a sense of why that occasionally might be problematic. But this is the risk of airline accidents per million flights up to 2017. And you can see there's been a dramatic reduction in the risk of a crash when you're flying. Okay, so a 20-fold reduction over about 40, 50 years. That's phenomenal. We all feel very safe flying. We don't like flying because of all the delays and hassles, but we feel relatively safe getting on a plane. It's not just the airline industry that's been successful at reducing errors. This is the Frito-Lay factory. Okay, they've gone almost 300 days without an injury on their first shift. Okay, so it's not just obviously the aviation industry. It's a lot of other industries really have done a good job at managing this problem. This is probably where we are. Okay, so I think all of us who work in hospitals, we recognize a lot of near misses. There are a lot of problems that occur, a lot of events that probably shouldn't have happened, but it's a very complex system. So I think if you look carefully, we probably don't go 3 days without a problem being identified, either a near miss or a real event that can cause patient harm. So we're probably somewhere here. And I would say that trauma is particularly vulnerable to errors. It really is the perfect storm. Much of the activity occurs after hours. The problems are very time sensitive. You don't have time to think through things. You don't have time to talk to people. You're dealing with patients who have very limited reserve. So if you make a mistake, some sort of error, sometimes some sort of delay in decision-making, there will be an adverse outcome. You really don't have histories. You're often doing multiple things at the same time with multiple providers. You know, the average trauma response at Sunnybrook has general surgery, ortho, anesthesia, RTs, a TTL, 3 different nurses. There's a lot of different people, and if communication isn't as good as it could be, there will be problems. There's frequent transitions in care between the ED, between ED and the OR and the ICU and the wards, lots of different transitions, and a lot of junior providers who really don't have a lot of experience. So it is truly the perfect storm for medical errors. And when you look at this picture, it's pretty clear the analogy, if it hasn't broke down, it really should break down. Okay, so look on the right. It's totally calm, controlled. The pilot and the co-pilot really have a lot of information coming to them. It seems much more controlled than what you see on the left, which is the typical trauma patient that comes in that's combative. You have to get control of the patient. Then you got to figure out what's wrong with the patient. And, you know, patients present in different ways. So you can see how the analogy might break down just by looking at these 2 pictures. But it goes deeper than that. In fact, the analogy breaks down, it's as if there's an evil genius who's inserted themselves into the system to create problems. The analogy breaks down because in medicine, there's this concept of trained perfectibility. So errors truly are marginalized and stigmatized. Okay, this occurs, and we're exposed to this early on as residents, and it continues. We're supposed to be perfect. You know, no one recognizes when the day went well in the OR. People really recognize when there's a problem. There's no tradition of reporting and learning from errors. So, you know, we do our M&Ms, we move on to the next thing. We really don't lead to sustainable solutions from those reviews. There's a huge diversity of activities and equipment. So pilots fly maybe 1 or 2 different aircraft over the course of a relatively long career, Airbus, Boeing, whatever. Healthcare providers are exposed to a very wide variety of equipment. In some hospitals, as an example, there's up to 40 different types of infusion pumps. You know, surgeons are often handed something in the operating room they haven't seen before. I haven't seen the stapler before. Where did it come from? So that's not unfamiliar to us. It'd be very unusual in other industries. In surgery, there's a ton of hands-on work. Okay, when you think of a flight between, let's say, New York and Paris or London, I don't know, 6 hours, maybe 30 minutes of that is hands-on. The rest is autopilot. When you think of a surgeon doing a lap chole, it's completely hands-on. There's no engineered defenses. There's just skill. You know, the critical view of safety to avoid transecting the bile duct. That's what we focus on. Imagine if pilots had to focus on, you have to see a cloud here and a cloud there, and everything else in between is fine. You know, it's pretty unsophisticated. It's all surgeon skill. We have patients who are vulnerable. And because we feel bad for our patients, we feel for our patients, We tend to, bypass critical protocols and safeguards that are designed for patient safety. The pilots have no relationship to us. They want to live, we want to live. We have that in common, but that's it. They actually are just doing their job. And in medicine, there is no aggregation of experience. So it's rare that we, as a group of academic health science centers, will have combined M&Ms where we can say, yeah, I've seen that before. The solution we used was this. That doesn't happen. In other industries, that does happen. So this is not new information. The patient safety movement really began in 2000 with this Institute of Medicine report, To Err is Human. And in that report, it was really recognized that humans make mistakes and adverse events are common. And it's estimated in this particular monograph that adverse events occur in up to almost 4% of all hospital admissions. Half are due to medical error. And they estimated there were almost 44,000 deaths per year due to medical error. So that was the same number of deaths due to car crashes around that time. So significant healthcare problem. There's lots of debate about whether that 44,000 was right, but nevertheless, there is a problem. It's just a question of the magnitude of the problem. And the Institute of Medicine report really focused on designing safety into the system. So the goal here is to create systems that make it really, really hard to do the wrong thing. So think of when you get into the car in the morning in your decaffeinated state. If you had to remember to put the car in park before turning on the ignition, that would be a problem. Every morning would be a little bit of a risk. Okay? You can't turn the ignition on without the car being in park. Okay? That's an engineered defense. The other thing that was a major focus of that monograph, we have to stop blaming individuals for past errors and focus on the system. And we've all heard this, but I'm going to give you a sense of how nothing has changed over probably almost 40 years, still doing the same thing. This is a nice study from Harborview. So I worked at Harborview for about 8 years. This is a trauma center in Seattle and one of the busiest trauma centers in the United States. And this study came out just actually as I was leaving Harborview. And they looked at preventable deaths in their organization over about a 9-year period. This is 44,000 trauma admissions, 2,600 deaths. And they identified deaths by looking at patients who, based on their types of injuries, had a low probability of death but died. And they identified a number of patients who merited further review through M&Ms and trauma performance improvement processes. Ultimately, what they found over these 2,600 deaths, that there were 54 errors. So an error rate of 2.5% of all deaths. And what's really neat about this is this was presented at the American Surgical. It was a big deal, but they repeated the study almost a couple of decades later. And they just published this just 2 years ago. And okay, so this gives you a sense of what was known and up to 2006. Okay, so just around the Institute of Medicine report coming out and just after that, and how have we evolved over time? Okay, so they looked at their error patterns over time. And you can see here that certain things have changed. So the rate of errors due to failure to control hemorrhage actually dropped significantly, okay, from 28 to 13%. Airway management errors, causes of death, increased from 17 to 31% over that same time interval. Nothing else really changed in terms of the patterns of error. So they got better at stopping bleeding, greater problems with airway management. And in fact, when you look at the paper, a lot of these airway management problems were major aspiration events on the ward. And I'll speak to that shortly. When you look at the phase of care, so where were the errors occurring? So in the earlier era, the errors were occurring in the ICU. I was the ICU director at that time, so it doesn't look good for me. But over time, after I left, those errors dropped from 37 down to 21%. The errors now were occurring on the ward. So I think this is probably because the population changed. There were a lot more elderly patients on the ward now, and their demographics have changed in trauma. And these, again, were probably aspiration events and other complications. So there was definitely a change in the types of errors, where they occurred, when they occurred. But overall, actually, the preventable death rate did not change. In fact, it went up a little bit. from 2.5 to 2.9%. So in spite of the Institute of Medicine report, us knowing what is supposed to change within our organizations to improve the quality and safety of care, actually we've gone nowhere. We may have prevented one problem, but other ones are new and different, and we haven't necessarily addressed those. So the limitations in this paper and many similar papers is they focused on identifying active failures. So active failures are those that occur by the provider at the bedside. And they looked in detail at these active errors. Okay, there's input errors where basically the provider didn't really understand what was going on and they couldn't really come up with a good plan. Well, the rate of those errors didn't change over time. There's intention errors where the doc, the nurse, understood what was happening, but actually led to the wrong plan. That didn't change over time. Execution error, where the provider knew the problem, knew what the right solution was, but executed incorrectly, that didn't change over time. So active failures and the reason for active failures did not change, but this paper and many similar papers completely ignore latent errors, the system factors that lead to these problems. And that's why there's been no progress over time. So active versus latent errors. Active errors occur at the level of the provider and the effects are felt almost immediately. Okay, so this is wrong site surgery, retained surgical instruments. This is us. We feel terrible when this stuff happens. Latent errors are those things that are removed from us. And they include poor design, bad maintenance, bad management decisions, bad organizations. That leads to active errors. And probably the best example of this is the Boeing 737 MAX. So you might remember, this is all pre-pandemic now. It seems like ages ago. There was a Lion Air and then an Ethiopian Air that fell out of the sky. And obviously the initial investigations led to an active error. The pilot crashed the plane. But after all the investigations were said and done, this actually had nothing to do with pilot error. There was a series of latent errors. There was a design malfunction. Boeing put into place this maneuvering characteristics augmentation system that actually there was no training around. No one really understood how it worked. They put that into the planes. They didn't teach the pilots. There was poor communication. Again, nothing in the training manuals. There were production pressures to get the Boeing 737 MAX out to compete with Airbus. The FAA really failed in their oversight. And ultimately, in flight, the plane rolled unexpectedly and the pilot had no idea how to control it. So we start by blaming the pilot, but when you look deeply and when you look in a far more complex way, you actually can understand the errors that led to the problem. And that's what we're really not good at doing in medicine. Here's another example. So this is outside of trauma. And we started looking at these events because we had a cluster of them over a very short period of time. So Mrs. K, undergoes a Whipple, admitted to the step-down unit, and it does well, is transferred to the ward on day 1, has some bloating, tolerating her diet. Then on day 4 has some nausea. She's got reflux, she's kind of distended. On day 5, her diet's held. She feels unwell, she's bloated. On day 7, she aspirates, has a cardiac arrest, transferred to the ICU and dies the next day. So, this is reviewed at M&Ms. And, what's the problem? Well, the problem clearly is the resident should have put the NG tube in on day 4. Clearly, this is the problem. And this is an example of oversimplification. Okay, so when you look at what's out there in the literature, if you want to prevent aspiration events, it's actually a much more complex problem than the resident remembering to put an NG tube in. In fact, we've looked at this in detail now, and probably one of the major risk factors for aspiration is having high-risk patients eat their meals in bed. So we created an aspiration prevention bundle. We've rolled it out on our surgical oncology unit. We're rolling it out now on our trauma unit. But basically, the expectation is that high-risk patients are identified with an SLP assessment. They get the right diet. They get up in chair for meals, which is surprisingly difficult given our human resource issues. We have created guidelines and directives for NG tube placement because there's this natural NG tube aversion because of ARAS. NG tubes are considered to be a failure, but 10% of patients will need an NG tube. That's okay. But if we avoid putting it in when it's necessary, it's a problem. And we review every aspiration event to see what potentially was preventable. So this is an example. In patient eating meals in bed, you can see how we've made progress over breakfast, lunch, and dinner. That progress took place over almost 3 years. Things are on hiatus because of the pandemic. We're reestablishing this again because we're rolling it out more broadly. But getting patients out of bed for meals is unbelievably challenging. But the other components, I think, will add to our success as well. So big focus on this. This isn't an NG2 problem. This is a much broader problem. And if you want a solution for it, you have to think more broadly. So who taught us all about this, about errors and reasons for errors and so on? It's James Reason. So James Reason was a cognitive psychologist, I think professor emeritus of psychology now in the UK. And he really recognized that humans are fallible, and focusing on human solutions to problems isn't going to be the answer, and that we actually have to change the environment around people to keep things safe. And we've heard this before. We just have trouble executing on it. And when we focus on trying to address a human failure and telling people to do better, remind them to do better, that's not going to work because they didn't intend to do this in the first place. And error management is all about making good people excellent. So he was the one who developed this Swiss cheese concept that many of us are familiar with. But I'm going to take you through an example of actually how this plays out. So when you think of the Swiss cheese theory, that basically if everything lines up, something bad happens. Well, there's risk factors and there's defenses against those bad things. So the risk factors are people are busy, there are lots of stuff going on, distractions are problematic. There may be a lack of standard operating procedures. There might be bad technology, deferred maintenance. Things don't work because there's other priorities. No one's held accountable for making sure the right things happen. Training is kind of sporadic. We have a lot of new people working in our hospitals now because of HR challenges. We have residents turning over. Training is probably suboptimal as we orient people to our organizations. And policies might not be optimal for getting the best out of people. So those are all the risk factors that lead to something bad happening. And the defenses are good policies and procedures, us, our nursing teams, and so on, highly trained professionals, high-performing teams who work together. So it's very important that we have each other's back. That's a defense. Good equipment. And ultimately, again, this is the provider problem. The provider is the last defense that will ensure the right thing happens. And it's not fair to them. When you see how complex systems are, it's unfair to hold the provider accountable for every problem that happens. Okay, it goes way back. So I'll give you an example of how this plays out. So this is one day at Sunnybrook, and we try to do the right thing every day. This is a young gentleman who had a bad motorcycle crash, had an open tibia fracture, has multiple INDs by ortho. So patient goes back to the OR, the wound is cleaned up, and ultimately plastics is consulted for a skin graft. Patient probably goes back to the OR like 3 or 4 times. And patient's brought to the OR for a skin graft for soft tissue coverage. Patient undergoes a GA, the dressing is removed, and the wound's already closed. So the error here is unnecessary GA. It's not a big problem, but it probably was better if it didn't happen. And everyone's saying, well, why didn't the surgeon or the team evaluate the wound preoperatively? Like, what happened here? So we would focus on blaming the surgeon. But let's take the Swiss cheese approach here and really understand what happened. Okay, so the result was an unnecessary general anesthetic. We're blaming the surgeon. Okay, the plastic surgery teams and the orthopedic teams are all very busy, and they probably didn't fully communicate to each other. In reality, what happened here is that during one of the INDs in the OR, orthopedics just closed the wound, and no one was told. So heavy workload, poor communication. There was no op note dictated. There was no short procedure note dictated. So no one knew that the wound had already been closed. But the biggest problem, and I hate this problem, and I focus on this problem all the time, is we have this ability, much like in your centers, to copy and paste notes in the EMR. And every day, and in the note, it said plastics to organize skin graft, plastics to organize skin graft, day after day, the same verbatim text. So there was no reason to believe that the wound was already closed. And that we let these EMRs with their problematic issues around copy and paste into our organizations as a reflection of safety culture. So I spend a lot of time dealing with copy and paste now, because if you actually look at copy and paste, it actually does lead to a lot of problems. So again, we blame the surgeon for not looking at the wound, but the problem is actually much deeper than that. And we're actually working on the copy and paste problem. There's good evidence-based solutions for this, but it begins with that. And the secondary problem was the absence of a requirement for procedure notes after the OR was done. Now we have that in place. Okay, so this is an example. If you dig deeper, it's actually, these are much more sustainable solutions, and it takes the pressure off the provider. Now, getting back to the aviation analogy, it's not perfect, but we can learn certain things from it. The aviation industry came up with the safety reporting system that is run through the FAA and NASA and a variety of other federal bodies. And ASRS is designed to take in all of these near misses, all of these risks on a daily basis. And this is completely anonymous reporting if necessary, or you can identify yourself, whatever. But basically, every working day, there's almost 300 reports of near misses, problems, and so on that are aggregated at the level of the FAA so people understand what's going on. And again, for those of us who fly, 265 incidents per working day is scary. Actually, just pre-pandemic, it was almost 400 per working day, but over the pandemic, things have come down. This is from 2020. So they have a system in place where you can report information, near misses, problems, and that is aggregated. That aggregation is very important because you see patterns. Events are typically rare, but when seen like this, you can actually come up with sustainable solutions that prevent the next such event. So we developed a similar reporting system through our trauma quality improvement program. And it acknowledges that preventable deaths are rare. You saw from the Harborview study, maybe 2.5% of all deaths. When you look at a death here and a death there, it's really, really hard to identify a pattern. And at the center level, you know, people will consider this as a one-off. It's not going to happen again. But when you aggregate the data over many centers, you can actually see patterns and problems that might lead to sustainable solutions. So that was the idea behind our mortality reporting system. We rolled this out in 2018. And the way this is designed is there's a website that you can go to. In fact, it's completely de-identified, confidential. Even the IP addresses are masked because there's lots of concerns around discoverability. But you know, you enter your event into this reporting system in a very structured way that goes along with JCO taxonomy that speaks to the provider, the setting, and a variety of other things. So it's really a structured way of entering the data, but it's completely anonymous. And ultimately, it's aggregated by us. We look at the data and we find hopefully sustainable solutions. So our first report came out of this just last year, published by Julie Hamad, one of our general surgery residents. And it's amazing what we learned through this. We learned something different than I anticipated. So again, the goal with this is to disseminate mitigating strategies so that every center doesn't have to figure out what they need to do to prevent a similar event. Okay, so there's no reason that every center has to reinvent the wheel. So we've had probably now over 500 reviews. We've changed the platform now to make it easier to report events. And that change in platform is going to lead to a further increase. And our plan is to disseminate these reports and learnings on a quarterly basis. So we're working with an editor to do that, but ultimately these are going to get out on a quarterly basis. So what did we learn? So when you look at the deaths, probably 25% were unanticipated deaths. You wouldn't have guessed this based on the comorbidities or injuries with opportunity for improvement. And 75%, the injuries were bad enough, the patient probably would have died, but there was still a problem with the way care was delivered. And here is a perfect case that is not all that uncommon. We see it here. It's all over that reporting system. Okay, so the attending on call was the trauma medical director. A patient comes in, 74-year-old male, post motor vehicle crash. They're hypotensive in the field. Their initial ED blood pressure is 72, so they're in shock. They do a trauma series. Chest X-ray is normal, pelvis is normal. The FAST is positive. So for those of you who don't do trauma, FAST is basically point of care ultrasound. If there's fluid in the abdomen, we consider it to be blood. And the short answer to this problem is hypotensive patient, blood in the abdomen is an operation. This is kind of a no-brainer. So this patient responses and volume to blood. The blood pressure hovers in the low 90s. The trauma surgeon decides to get the patient to the scanner because it's going to be a quick scan. Lo and behold, there's hemoperitoneum, there's a shattered spleen, there's a mesenteric injury, and the patient crashes towards the end of scan and ultimately makes it to the OR, but was profoundly hypotensive, transient arrest, gets to the OR, has their splenectomy, has their mesenteric injury fixed, but ultimately dies in the ICU. Okay, so this for a trauma surgeon is a short putt. Okay, it's positive fast, hypotensive patient is an operation probably 95% of the time. I'm going to come back to this case. We're going to analyze that case in more detail. But in the mortality reporting system, these are the causes of death. So no surprise, about a quarter of deaths are TBI, about 20% are due to bleeding. And there's a smattering of other things, PEs in about 1%, which is much better than it used to be. Multiple organ failure, airway deaths, hypoxemia, infection, a wide variety of things. TBI and bleeding is not unexpected. When you look at common causes of death with opportunities for improvement, okay, bleeding. Very challenging sometimes to actually make the decision. Do you go to the operating room? Do you go to interventional radiology or the scanner? Very similar to the problem we just had here. Issues with massive transfusion protocols not being effective or people not calling an MTP when necessary. TBI-related deaths were a wide variety of things. There was actually one example of CT scanner that was brand new in the operating room. The team decided to scan the patient in the OR. No one knew how to use the scanner. There was a variety of medication errors. Then there were a bunch of deaths due to infections and other complications that typically occur on the ward. And these deaths are considered to be failure to rescue. A complication with ultimate death is a failure to rescue, and it's a quality indicator. Failure to recognize deterioration is a big problem on our wards. So that's not an uncommon problem. Airway failure to secure, and multiple organ failure deaths, a wide variety of things, missed injuries, EMR downtime protocols that were ineffective, and so on. But this gives you a sense of some of the challenges. When you look at the deaths, human failures were at the root of the problem in about 60% of cases. We divide human errors or failures into slips and mistakes. So slips, I'll go into these in more detail, are either a slip of action or a memory lapse. So an example of that is, you wake up in the morning, you're making coffee, you're pouring orange juice, you pour cream into your orange juice. Okay, that's a slip of action. And then there's mistakes that are either rule-based or knowledge-based. So a slip is someone who knows the plan, has knowledge and expertise, you just execute it incorrectly because you're distracted typically. A mistake can either be rule-based or knowledge-based. A rule-based mistake is there's a protocol, there's a plan, the provider doesn't know which plan to use or just violates the plan. And there's knowledge-based mistakes where there's usually more complex problems. There isn't a protocol, there isn't really a plan. You kind of trial different things and it doesn't work. Okay, so there's slips and mistakes, and you'll see who makes the slips and who makes the mistakes. There's different types of providers. Okay, so slips are things that are basically a reflection of us getting distracted or tired, and mistakes are not following protocols for a variety of reasons. So slips are the domain of experts. This is us. Okay, again, slip of action or memory lapse. And these are prevented by better workplace design, not being tired, using checklists, independent checking, which is very rare in healthcare. Independent checking, the nurses will check blood. 2 nurses check blood if we're transfusing blood. There's very little independent checking otherwise. Discouraging interruptions, but what's clear is that education and discipline are not effective for this. Okay, you'll see how often we resort to education and discipline, but it's not effective for slips. Cross-checking, again, is when 2 people do the same thing to ensure there's some redundancy and the right thing happens. This happens all the time when you're sitting on a plane. You hear the pilot who asks the flight attendants to cross-check each other's doors. They just make sure the doors are either secured or unsecured at the time of landing and ready to disembark. Okay, we don't do much cross-check, but cross-check is one way to ensure that slips don't happen. So when you look at the mortality reporting system, who's most involved? Okay, almost 60% of the cases, the attending is involved. Okay, it's the attending who's holding the ball when the error occurs. There's a small number of cases that are resident error, PAs, NPs, nurses, but mostly it's the attending, the expert. Now, mistakes, how do you prevent mistakes? So mistakes are prevented by making sure that you have the right people doing the job and they're well trained. So competency assurance processes work. If you bring on new trainees into an organization, you haven't oriented them, that's a competency assurance process. It's good quality training, proactive supervision. The attendings are there, the seniors supervise the juniors and so on, and the team climate ensures the right things are more likely to happen. Okay, so the solutions to fixing mistakes are very different than fixing slips. Okay? Mistakes are more around education, and slips are really around better working environment and avoiding distractions and fatigue. When we looked at the mortality reporting system and identified what the solutions offered by centers were, they were ineffective solutions. So here we go. So again, these are attendings for the most part who are making the errors. So the solutions, well, we reviewed the ATLS protocol with the providers. Okay, so anybody who works in a trauma center knows what's supposed to happen in ATLS. Okay, reviewing the protocol is nonsense. Resident education and antibiotic timing VAP protocol. Okay, well, we'll educate these residents, but the next set of residents will not have been educated. We'll have to do the same thing over again after a mistake occurs. The attending will be re-educated. Okay, well, it's often not an education problem when the attending's involved. Education to trauma providers and nursing. Simulation of head CT setup in the OR. Simulation works, actually. That's actually a very good solution. The APP, the advanced practice providers, to be counseled because there was a slip. So the mitigating strategies are highly education focused. Here you have a sense of that. So almost 60% of strategies that were offered by centers were all around educating the provider. Simulation underutilized. About 20% of cases actually had no idea how to prevent the next event. Policy or guidelines in 17%, a change in human resources equipment in a small fraction as well. But the default here is let's just re-educate people. Okay, it doesn't work. And just to summarize here, mistakes occur because people don't know what to do because they haven't been taught or they haven't been trained. That's where education is effective. But for these other things, training and education really doesn't have any role in making us less likely to slip up. And now when we review cases, and when we review cases at the hospital level with QSIPA, we always have this diagram up. This is the hierarchy of intervention effectiveness. Okay, so the most effective solutions are forcing functions. So you cannot hook up nitrous to the oxygen intake of a ventilator circuit. It's impossible. They don't connect. Okay, we have very few forcing functions in medicine. The bottom of this is education and training. That's people focused. Doesn't work all that well. So what we always try to do now when we create solutions and what we're trying to educate the TQIP community and our trauma center community is they have to think differently about their solutions. They have to at least go to rules and policies, checklists, simplification and standardization, ultimately automation and computerization. There's very few forcing functions that we could enable, but certainly a little bit more system-focused approaches are going to make a big difference. So when you do your M&Ms and your answer is education, think differently because it's not going to be effective. It'll be effective maybe for that rotation, but as the residents turn over and everybody turns over, it's gone. So this is a very important thing to do, to look at when you're reviewing your cases. Now, why do these errors occur? So I think we all appreciate the unbelievable capacity of the human brain, logic, abstract thought, emotion, creativity. I have here Katherine Johnson, the mathematician in Hidden Figures, who was behind the orbital mechanics that led to getting a rocket ship to the moon. I have Picasso, Mozart, Freddie Mercury. Like the brain truly is incredible. And I think we're always impressed by our colleagues who can do incredible things and the artists and scientists out there. But the human brain has its limitations. And we often deviate from making the right decisions because our brain tries to actually reduce glucose utilization. There's information processing shortcuts. We have a limited processing ability. We're affected by emotions and morals around us that might lead us to the wrong decisions. We can't always retrieve the memories that we want, particularly under stress. There's social influence. Together, these are called cognitive biases. And cognitive biases are at play when we have those slips. In fact, there's about 210 different cognitive biases. You can see here the anchoring effect, where you focus on one piece of information and that directs our decision making. There's the gambler's fallacy on the top right, where basically, it's happened twice before, that probably that happening again is like zero. There is confirmation bias, that you focus on a piece of data that confirms your own intent, and that leads to problems. Again, there's 210 different cognitive biases that make our mind occasionally lead to the wrong choices. I love this one. This is the IKEA effect, where we attribute greater value to something that we created ourselves. And for the general surgeons out there, you create the anastomosis, it looks great. What's your anastomosis? This is the IKEA effect. Okay, so we attribute greater value to something that we ourselves created. Let's go back to this case and try to explore what cognitive biases were at play here. So the attending on call, again, was very experienced, was the medical director of trauma. Patient comes in, elderly hypotensive patient with a positive FAST, no brainer for us, short putt to the operating room. This patient doesn't have that trajectory. They get some blood, they get a CT scan, they crash at the end of scan, and ultimately they end up dying. Okay, so let's take this apart. Okay, so the patient had transient response to blood. Okay, well, the trauma surgeon focused on that as a positive. And irrespective of the fact that the patient was really hypotensive, patient was sick, they focused on that one piece of good information. Planning fallacy, tendency to underestimate task completion times. Well, that is a not uncommon problem in surgery. CT scan is never quick. Information bias, tend to seek information when it can't affect action. Authority bias, no one's going to question the TMD because they're the boss. Overconfidence effect, the TMD knows what they're doing. No one's going to, he's not going to question his own decisions. And availability heuristic, well, there may have been a similar event recently that CT scan made a difference, but in most cases it doesn't. Lots of cognitive biases at play. So how do we move the needle? Okay, so a lot of this is really around creating standardized processes to make a difference. When we look at success in TQIP, the centers that standardize things, which is higher on that hierarchy of effectiveness, lead to better outcomes. And this is all really pushed forward by Taichi Ono, industrial engineer at Toyota. He focused on Kaizen, improvement, and felt that there was no possibility of improvement if you didn't first standardize. And standardization is so critical. It clarifies the process. It makes training people easy. It reduces variation. It also provides the baseline for quality improvement. If you haven't standardized anything, there's no way to improve. You have anarchy. You have to have a baseline to begin with. But it really, really helps training and sets expectations. Checklist and double check. So this is our trauma bay checklist that we put into place a number of years ago. It works. We used to forget to send patients blood for cross match. That never happens anymore. The checklist works. I think that we can probably use double checks a little bit more frequently. We almost never do that with each other. Simulation. Simulation is very effective. We underuse simulation. We know in pediatric TQIP centers, those centers that use a lot of simulation have better outcomes, better processes of care because they practice. They identify the flaws in their system, they address them before they hit the patients. So we're just a bit out of time, but I'm going to just focus on these take-home messages. The provider at the sharp end, the one holding the ball when the adverse event is going to be all of us. When you look at these problems and these cases, don't oversimplify. Look deep, look several layers deep. And when you're creating strategies for preventing these adverse events, go up on that hierarchy of effectiveness. Okay, consider the fact that people are going to change over, people are imperfect, and design sustainable solutions at the system level. And with that, I'm happy to answer questions. I'm also, again, honored to have given the tile lecture this year and just want to recognize Dr. Rutka's leadership over, I think, 11 years and his wise counsel and support, I think, of all of us over a fantastic decade. And I'm just so pleased to be a member of the department. So happy to answer questions. I realize there's only a few minutes left.
Great. Thanks very much, Avery. That was spectacular. I really liked what you said about the electronic medical record copy paste errors and function. I mean, we're all kind of prone to that, and I hate seeing copy and paste when it appears all the time. You can imagine how much can go wrong with that kind of broken telephone line situation. We will open to questions. I might just start by asking a question, Avery. And you did this, and you published on this recently, where you took information from a variety of trauma centers, and you collated responses and came up with solutions. But it sort of points towards complicated solutions with which may be aided with machine learning. So imagine if you had an issue with airway management that you wanted to solve, and you took all the airway management issues across the entire United States, Canada, and around the world, and used a machine learning algorithm to collate those. And you know, the number of those problems are probably not infinite, but they're going to be, you know, dozens and dozens of them. But that number might be reduced to a very manageable means by which machine learning can organize things for us. So what would you say about that approach to finding solutions this day and age?
I think that it's a tremendous opportunity. So there's no reason, like if you had the system set up with information about a patient's presenting blood pressure, let's talk about that case that I presented, and you had access to the experience of thousands of similar cases where the solution was evident through a machine learning algorithm, you'd come to the right solution almost always. Airway management, same thing. Those systems don't exist yet, at least at point of care. They are being developed, and you know, we're playing with machine learning using our data set to try to predict who will require a massive transfusion, as an example. But it's using those at the point of care that are problematic. We just have to figure that out, but definitely a solution.
Great. Other questions? Ava, I might ask, you know, that case that you presented of the patient who went to CT and went to the OR and then ultimately died. I mean, I could argue with the patient would have died anyway. I mean, if you went right from fast, let's say, to the OR with like, let's say there was something unexpected on a CT that would have helped you use an interventional approach versus an open surgical approach. I mean, maybe it would have been worthwhile to get that information. You said mostly not, but what's your thought about that? Was that an inevitable outcome, no matter whether you went to CT first or you decided just to go right to the OR?
Yeah, with those injuries, that's a salvageable patient completely. You know, sometimes we are pushed to the scanner if someone has, you know, abnormal pupils, head injury, but in a patient who comes in hypotensive with limited reserve, and that's an elderly patient, limited reserve, the solution is just a quick operation. And the CT scan, we say it's quick. The scanning itself maybe takes seconds, but transporting the patient to the scanner, getting the patient off the scanner, it's an hour. So it's an hour of unnecessary hypotension in a patient with no reserve. It makes a difference.
Great. Thanks, Avery. Other questions? Okay, I'm not seeing anything in the chat, and we are just past the hour. So Avery, I think on behalf of the Department of Surgery, I'll wind things up and just thank you so much for giving this year's tile lecture. And again, I'm honored and just delighted that Marvin could join us today for the tile lecture in his name and honor. And Avery, this was a spectacular lecture, and you really have shown us how you've been a leader in trauma care, in quality improvement over many, many years. And we thank you for that in the Department of Surgery. So folks, yeah, we'll wrap it up. As Avery had mentioned, this will be my last Department of Surgery rounds that I've been hosting. There have been over 100 of them in the last 10 years that I've been personally very proud to have been a part of and to have listened to. Tremendous value, I think, to our faculty, great speakers, and today was absolutely no exception. Thanks to all of you for joining, and I wish you all well. Everybody have a great summer. And Marvin, great to see you too. Stay well, everybody. Thanks, folks.
Thanks, everybody.
See you.